chronic illness and hearing loss and its effect on the quality of life of nursing home residents today on the podcast. The Nursing Home Abuse Podcast is dedicated to providing news and information for families whose loved ones have been injured in a nursing home. Here are your hosts, Georgia attorneys Rob Schenk and Will Smith. Hello out there. Welcome back to the podcast. My name is Rob, and I will be your host for this episode. Today, we're talking about an issue that I think is often overlooked, and that is how hearing loss in nursing home residents is affected by chronic illnesses, medications, and other factors. And as a result of hearing loss, how quality of life can suffer. So this is a systematic problem in many nursing homes because assessment tools maybe aren't the best, and staff that does the assessments that review a resident's ability to hear perhaps aren't trained in a way that would bring about the type of care that would allow the resident to attain the highest practicable health. So we are having on today an expert in this area, Dr. Kathy Dowd. She is an audiologist, and to talk about all of those things: hearing, chronic illnesses, balance disorders, assessments, and changes to nursing home ways that would help quality of life of residents. So before I got her on, let's learn a little bit about her. Dr. Kathy Dowd received her undergraduate degree in French education from Spalding University, a master's in audiology from the University of Louisville, and a clinical doctorate from Salus University. Her background in audiology over the past 39 years is varied: educational audiology at local and state levels, as well as a private practice in ENT and proprietary clinics. For the past 5 years, Dr. Dowd has worked to raise the awareness of chronic disease and ototoxic medications causing hearing loss by instructing diabetes educators, optometrists, and audiologists nationally about this silent, unmet medical need. In April 2016, her advocacy efforts moved the Centers for Disease Control to consider a recommendation for hearing testing to the patient guide, Take Charge of Your Diabetes. Dr. Dowd is heading the advocacy and collaboration of audiology organizations and setting clinical guidelines for patient care in the area of chronic and infectious diseases. And we, again, are so happy to have Dr. Dowd on the show. Dr. Dowd, welcome to the program.
Thank you, Rob. I'm glad to be here.
Excellent. So, Dr. Dowd, we're so happy to have you on the show to talk about the issues surrounding chronic illnesses, hearing loss, and balance disorders, and how those issues relate to one another and in turn relate to the quality of life and the care that our seniors and specifically residents of nursing homes receive. So can you kind of, and you're the expert on this, so can you kind of unpack how chronic diseases like diabetes affect an individual's hearing, kind of, from a 40,000-foot view, kind of unpack that for us?
Oh, certainly. Well, the Audiology Project is focused on diabetes and the effects on hearing and balance, but we also know cardiovascular disease, chronic kidney disease, Alzheimer's, Alport syndrome, Crohn's disease. All of these chronic diseases will have a negative effect on hearing and sometimes also on balance. In addition to whatever the person has experienced during life with noise exposure or medications, strong medications to treat infection like sepsis or MRSA, those also have an effect on hearing. So for diabetes, what is happening is it's a microvascular disruption in the body. And it's been known for a long time that this affects your eyesight. It affects your foot neuropathy, your feeling in your feet. It affects, even in your brain, you get this disruption in the microvascular system throughout the body, in your kidneys. So diabetes doesn't discriminate. It's everywhere in the body. Even in the ear, the issue with the ear is we can't look into the cochlea, which is the inner ear, to see this disruption like you might see it in the back of the eye. So, so that's a problem. And cardiovascular, though, is really macrovascular issues. That means large blood vessels. So if you have a tendency for blood clotting, pulmonary embolisms, strokes, even hypertension can cause your hearing to go down. Alzheimer's, again, if Alzheimer's is related to changes in the brain, that's where the receptor for the auditory signal is, or the receptor for your balance and for your orientation in space. So anybody in nursing homes who have chronic diseases needs to be tested. And the audiologist needs to find out all the different things that have happened to this person in their life that might have contributed to a hearing problem.
So if I understand it correctly, Dr. Dowd, it seems to be at least kind of two drivers for how chronic illnesses can affect the hearing. One is as you mentioned, the microvascular, meaning the blood flow. The other is kind of an interference with the senses and the receptors of the brain due to something like Alzheimer's. So you've got kind of, on one hand, you've got maybe strokes, diabetes, peripheral artery disease on one end of the spectrum, and then the other end you've got, dementia, Alzheimer's, that can all have an effect on a hearing, which is interesting because, growing up, at least all I remember learning is that you've got little hairs in your ear, and if they fall flat, that's what the hearing loss, that's how you get hearing loss, as opposed to what you've just mentioned. So that's really interesting. That's news probably to a lot of people. At least it's news to me.
Yes, I think many in the medical field are unaware of these causes and the need for evaluation.
Exactly. So at the top of the show in your bio, we mentioned the Audiology Project. Can you kind of talk about that a little bit?
Well, I started the Audiology Project probably about 5 or 6 years after my mother-in-law was diagnosed with diabetes. She was in an assisted living center. She already had a cardiovascular disease. She already had hypothyroidism, which contribute to hearing problems. And then she got this diagnosis of diabetes. When I reached out to CDC to get some material, knowing that she already had a hearing problem, which she wore hearing aids, but CDC was not aware of the relationship between diabetes and hearing loss. So over the course of the next 5 or 6 years, I was in communication with them. And then in 2016, I spoke with the Johnson & Johnson's Diabetes Institute, with the American Optometric Association about this issue for audiology, and they recommended we get all of our audiology associations together, bring them together for a stakeholders meeting. How are we going to move this issue forward and raise awareness of this new emerging issue? So in September of 2016, we formed the Audiology Project, and then just last year, in November of 2019, we wrote a definitive publication in Seminars in Hearing that explains the pathophysiology, what is happening to the ears and the vestibular system with diabetes, and then also how does audiology need to identify and manage this from both a hearing standpoint and a balance standpoint, because your balance system and hearing system are right next to each other, and it's one nerve. The eighth nerve comes off of both of them, sending the signal up to the brain. So the effects are for both systems.
I see. So before we get into that, can you kind of, is there a difference between one person's hearing loss versus another person's hearing loss, or even are there different types of hearing losses? If that makes any sense, like I don't know. Is that something? Are there different layers or different types, and that might work faster than the other in terms of loss of hearing?
Well, noise is probably the quickest damaging feature for your
Mm-hmm.
hearing, because you can have one incidence of extreme noise and lose your hearing totally. Certain medications, depending on your susceptibility to those medications, could totally wipe out your hearing. So and it's impossible for an audiologist to know until the person comes in. You take a really good case history, and then you test. It's impossible to know until you do the test. This is what it is. So there's varying degrees of hearing problems. It could be a mild hearing problem where it just sounds like people are mumbling. When it gets into moderate and severe, you're actually missing critical aspects of speech. You can hear somebody, but you're really having much more difficulty understanding. And then a severe to profound, by that time, it would be unusual that your hearing was not evaluated before that time. Although, again, you could have a sudden hearing loss from some of the things I just mentioned, and it could go overnight. So, but normally the progression could start with a mild hearing loss and then progress to severe or profound. About 10 to 15% of hearing problems can be medically or surgically corrected. So once the audiologist tests you, they're going to know if there's a chance you can have medical treatment or surgery that's going to reverse the hearing problem, and then a referral is made. So,
tell us about the test then. Like when should somebody be tested, and what is involved in the test? Is it literally like your hands on the patient, like you got to go inside the body? Can you kind of talk about that a little bit? What can we expect from that?
well, when you go to the audiologist, usually what they do again is take a good case history, so we know all the things that have happened to you. Is it in your family? Did you shoot guns as a youngster and go hunting? Did you work in a factory? Do you have high blood pressure? Are you on medication for anything? And then that starts bringing up the chronic diseases. Then the audiologist looks in your ears to see if there's anything blocking or anything abnormal in the ear canal. It could be something as easy as a wax blockage. So removing the wax then does away with the hearing problem, because the wax was blocking the sound waves from going into your ear and hitting the eardrum. We examine the eardrum, make sure there's nothing that looks abnormal with that, no holes in the eardrum. We can't look beyond that. So then, again, we take the case history, but then we put you in the booth, and we put headphones on, and then we put a bone conduction oscillator behind one of your ears, on the bone right behind your ear. So we test air conduction with the headphones on, and you're given really tiny beeping sounds, and you're supposed to press the button as soon as you think you hear it. And it'll be different pitches, and they'll do one ear and then the other ear. And then they do bone conduction, and that just sends the signal directly to the cochlea. It bypasses the middle ear or the eardrum, and it finds out how well you can hear just in the cochlea. And we can chart that. And then there may be some other tests that are done too. For example, otoacoustic emissions. That is examining your inner ear hair cells and how well they're functioning. Sometimes you could have normal hearing, but you're going to show up with a problem with OAEs, with otoacoustic emissions, which tells us there may be some damage occurring. So we need to keep a check on your hearing over time.
It's
We also do tympanometry, which moves the eardrum back and forth and makes sure that it is moving, because if it doesn't move, then there's some problem on the other side of the eardrum. Maybe the little middle ear bones have stiffened up. And that's an issue that can be corrected usually by an ear, nose, and throat. An otolaryngologist can do surgery to correct that. So once we're all done, we have a picture of your hearing.
yeah, and I wish that every time. Well, let me back up. Um, Federal and state law require that when a resident is admitted to a nursing home, that an interdisciplinary team consisting of the doctor, nurse, people that have hands-on care going forward, do a head-to-toe assessment of the resident. That's everything from cognition to whether or not there are wounds on the person. And you, in the process of doing that, you get history, you get the family involved for all the reasons that you just stated. But I don't just offhand. It's the minimum data set is the federal assessment, and I don't recall. I know there's hearing on it, but I don't think that it goes into the detail that you have described. Although I wish it did, and the reason why I wish it did is I would love for you to explain this. Is we've talked about chronic illness, we've talked about how it has the potential to affect hearing. We talked about how medication might affect hearing, and how to test for it, at least more appropriately than probably is done now. But at the end of the day, there is, at least in my experience, the misconception that, well, grandma can't hear very well, but all that means is that we got to turn the TV up for her. What does quality of life have to do with, or what's the correlation between quality of life, health, and the loss of someone's hearing?
Well, and that's one of the focuses of the federal law, the Omnibus Budget and Reconciliation Act of 1987. And it states that there needs to be assessment of hearing in order to ensure the best quality of life for the residents. However, when they wrote the CMS, the Medicare MDS assessment for hearing, I don't think they consulted any audiologists, because the intake nurse talks with the person, the new resident, face to face in a quiet room, and then comes away with this subjective determination of, oh, I think you could hear me okay. And so they mark that everything's all right. When in fact, what happens is one-on-one, face-to-face in a quiet exam room, even a physician won't see a hearing problem that's significant. And there's a lot of research that has come out recently that says that this CMS MDS hearing assessment severely under-identifies hearing loss. And I'm trying to raise this awareness with Medicare right now. I think they wrote this assessment probably back in 1987 when OBRA took effect. Yeah. But it's a subjective view of somebody's hearing, and it's not valid. It's not an objective screening.
Agreed. It's been a while since I've read the RAI manual, the manual that the MDS coordinator, whoever the nurse is conducting the hearing test for the MDS, what detail they go into. It's definitely not as you've described, but you're right. I mean, they notch off, can the person be understood, and is the person, can they understand from a hearing standpoint? And it really doesn't go very far, as you mentioned, into what you're talking about. But
well, and if the intake person would even cover their mouth when they're talking, I mean, that's going to take away the 40% understanding from lip reading. So if they would even do that, they'd see a little bit more. But you can't really know until you have a valid, objective hearing screening, not a discussion with the person, or a hearing evaluation. That's the only way to know. These people are coming into the facility from the hospital after having a heart attack or a stroke or diabetes that's out of control or kidney failure all of these things that just happened very recently in the hospital have a very potential impact on hearing loss. And it's not being addressed right now with the MDS hearing assessment at all.
Right.
So
So,
it's a problem.
and like I said, I understand, like, from a quality of life standpoint, if someone can't hear, that, you know, it might mean that they're going to self isolate, because they can't participate in things. But what else in your research have you seen? Like, what are the other, like, in other words, how does that affect, like, balance, hearing with balance, these type of things going forward, in terms of somebody losing their hearing and not wanting to walk anymore, maybe things like that?
Well, and hopefully the physical therapist, when they come in to do their evaluation, takes into consideration any potential vestibular problems that might be happening. We usually we do an assessment. The audiologist does an assessment by stimulating the vestibular systems and then watching eye movement. But there's some things that you can do statically to assess the person's balance. So at this point, what happens with hearing loss is it causes confusion, depression, and isolation. So the person doesn't want to come out to group activities like bingo because they're not ever going to win. They can't hear the person that's announcing the bingo. Or they're going to be depressed because they hear everybody talking around them, but they don't understand. They feel like they're talking about them. They're mumbling about them. So they get very suspicious. One gentleman that I tested in a nursing home, the CNAs, the aides said, after we identified his hearing problem and corrected his hearing, they said, "Oh my God, it's night and day." And I said, "What do you mean?" They said, "Well, we used to come in to give him a bath and he would physically fight us. And now when we come in, he can hear us explain what we're going to do and how we're going to do it. And so he's fine with it." And so obviously before he felt like he was being accosted and, nobody's explaining things to him. Where once he understood what was going on, it's like, oh, okay, yeah, I do need a bath. And he was fine with it. So it affects everything. And my issue right now is that nursing homes are allowing cognitive evaluations of new residents and cognitive treatment, and there is no hearing screening first, which in my thought should not be happening. You cannot assess somebody's cognitive status without first making sure they can hear well, or else correcting their hearing and then looking at cognitive.
That makes a lot of sense, and that example of the individual that was fighting the baths, that's the perfect example of how hearing can do wonders for the person's care. So how that would probably shake down without the issue with the hearing being resolved is that they're going to say that he's non-compliant. They're going to call the family. He's going to get ridiculed by the family, possibly. Dad, stop fighting them about bass, this type of thing. But by getting that hearing tested and he can understand what's going on, that's a night and day difference in outcome. Can you?
But a hearing loss is invisible.
Exactly.
It's an invisible handicap. So you can't tell. You just think, oh, they're not paying attention to me or they're ignoring me, when in fact they just don't hear you.
Correct. You've mentioned more appropriate assessment techniques for hearing loss, doing this prior to any type of cognitive assessment. You've talked about testing at regular intervals for these purposes based on a holistic approach, medications, history of chronic illnesses, these type of things. What other types of what I think that you have called in your writings and presentations the hearing standard of care? What other examples of the hearing standard of care should nursing homes be doing for either prevention of hearing loss, or caring for someone with hearing loss?
Well, when you consider that 80% of the people in nursing homes have a hearing problem, everybody needs to have an evaluation when they first come in. At least then you set a baseline. And so there's 20% of the people will have normal hearing, but they're still being given medical care or medications. They may suddenly get an infection, but at least you have a picture of where they're starting. So I think a baseline hearing test is the first thing that needs to happen. And then if you find somebody that can benefit from amplification from hearing aids, that needs to be the next step. The wonderful thing about hearing aid technology now is that you actually can get, when you go to the dining room in a skilled nursing facility, which is a little bit noisier, there's technology that actually takes down some of the background noise and allows you to hear the people in front of you at your table. And it makes it easier to hear in those situations. There's Bluetooth so that you can connect to an iPhone or a smartphone and have continual conversations with your family. And it comes right into your hearing aids. You don't have to put the phone up to your ear. The Bluetooth sends it into your hearing aids and makes sure that you can hear it.
Right.
And then just ongoing evaluations. I mean, we can't stop with just the initial assessment, but depending on your history, it may be in 3 months or 6 months that the audiologist needs to test you again. Has anything changed, or is your hearing stable?
Gotcha. Well, Dr. Dowd, this has been a fantastic conversation, one that is not often held with individuals that have a loved one in a nursing home, about how taking hearing loss seriously and understanding the appropriate ways to assess the loss and to take interventions and steps towards caring for somebody with hearing loss. So we really, really appreciate you coming on the show today.
Oh, certainly. Thanks so much for having me, Rob.
Absolutely. It's a reoccurring theme on this program that nursing home assessments, training, and family participation sometimes are not what they need to be, which in turn leads to a decline in the quality of life of residents. So I hope that we've all learned something today about how hearing loss is more than just, tell grandma to turn the TV up, that it has other ramifications in quality of life and the care received. So these are all important things, and we are very fortunate to have Dr. Dowd come on the show and talk to us about these things, because she's doing great work out there. All these things go towards quality of life and appropriate care in nursing homes. If you enjoyed today's episode, if you enjoyed the content of the Nursing Home Abuse Podcast, be sure to like and subscribe wherever you get your podcast from. If you got any suggestions or any comments, be sure to leave them in the YouTube comment section, or you can reach out to us at nursinghomeabusepodcast.com. And with that, we'll see you next time.
Thanks for tuning in to the Nursing Home Abuse Podcast. Nothing said on this podcast, either by the host or the guest, should be construed as legal advice, nor is intended to create an attorney-client relationship between the host or their guest and the listener. New episodes are available every Monday on Spotify, iTunes, Stitcher, or on your favorite podcast app, as well as on YouTube and our website, nursinghomeabusepodcast.com. Again, that's nursinghomeabusepodcast.com. See you next time.